Hello friends, in this series of chest x-ray, we will discuss few interesting cases based on radiology, especially chest x-ray. So we will discuss 7 cases and we will see its radiology. So let's see our case number 1. So this is 49-year-old male, known case of rheumatoid arthritis. Point to be noted, rheumatoid arthritis. He is having dry cough, fever and shortness of breath for 2 weeks. Bronchoscopy, we have ruled out tuberculosis. There is no bacterial infection, there is no fungal infection. In spite of no infection, we have given 5 days antibiotic, but there is no response. And there is no malignancy also. If you see this X-ray, you can see there are multiple rounded consolidation which is there and predominantly at peripheral area, and surrounding this consolidation there is ground glass opacity. So classical, this is patchy pneumonia like picture, but there is no infection. So in case of rheumatoid arthritis, if you find this type of opacity and patient not responding with antibiotic, you should think of organizing pneumonia. So in organic pneumonia, if you give steroid, so like in this patient, once we have given 10 days steroid, patient responded very well. This is the first X-ray and this is the X-ray after giving steroid. So classical organizing pneumonia secondary to rheumatoid arthritis. Now coming to case number 2. This is 35-year-old male, known case of atrial septal defect with mitral valve prolapse. He was operated in 2015, but he has acute breathlessness and cough for 5 days. He also had high grade fever for 5 days. So in the background of cardiac disease, if patient is coming with acute breathlessness, especially orthopnea, then you have to think of some cardiac related diagnosis. So this is the X-ray of this patient. This is chest X-ray PA view. In this X-ray you can see there is CP angle blunting, there is cardiomegaly, and you can see there fluffy shadows, some ground glass opacities, fluffy shadows which is there bilaterally arising from hilum. So there is from hilum to periphery. So in this background with this X-ray, you should think of cardiogenic pulmonary edema. So once we have given antibiotic and diuretics, after 3 days itself, X-ray got clear. Very good treatment. Steroid is the very good treatment for cardiogenic pulmonary edema. So this was the previous X-ray. This is the current X-ray. Drastically improvement. This is cardiogenic pulmonary edema. So if you talk about pulmonary edema, so pulmonary edema usually is difficult to differentiate on X-ray. In X-ray, in any edema, pulmonary edema, shadows are bilateral, diffuse, butterfly pattern, means arising from central going towards periphery. Soft, fluffy shadow like in our patients, and often we used to get ear bronchogram because there is filling of alveoli and bronchi with water. So in this case, we can get ear bronchogram also. So pulmonary edema, etiology wise, two type: cardiogenic, where the problem is cardiac, like congestive heart failure, and non-cardiogenic, like infection, ARDS. So these are the classification of pulmonary edema. So if we try to differentiate between these two, there are certain features which is there in cardiogenic pulmonary edema, like cardiomegaly usually present in cardiogenic pulmonary edema. This cephalization of vessels due to venous congestion, vessels going towards upside. So this is cephalization of vessels. Perihilar wetwing opacity means their hilar predominance as compared to peripheral. Smooth interlobular septal thickening. Okay, and we can find pleural effusion in many patients, like in our patients. Okay, so this is classical feature of cardiogenic pulmonary edema. If you see non-cardiogenic pulmonary edema like ARDS, in this heart usually normal size because cardiac problem is not there. The heart size is normal. No vascular congestion. and the opacity are more patchy, peripheral rather than central, and diffuse infiltrates. And there is no septal thickening. Pleural effusion usually absent, but you can find pleural effusion in few patients. This is non-cardiogenic pulmonary edema. Let's see our case 3. So case 3, this is the middle-aged man met in road traffic accident. So he brought in emergency with consciousness, gasping, hypotension, means severe injury. So whenever there is severe injury, you have to get chest X-ray done. Okay. So if you see his X-ray, you can find there is large pneumothorax and you can find this opacity. So what is this? This is collapsed lung. But this is not classical case of pneumothorax. This is fallen lung sign. Okay. So what is it? When lung is cut down by bronchi, so lung got separated, it's bronchi. So lung will fall down because of gravity. Okay, but it is not completely cut down from hilum. It is attached by vessels, vascular attachment. Okay, so this is fallen lung side. So this is not classical pneumothorax. So if you try to differentiate with pneumothorax, lung usually collapse towards central side, but in fallen lung side it is going down. In this X-ray, you can see there is bilateral pneumothorax. Pneumothorax is here also in left side. So in this X-ray, bilateral pneumothorax and pneumomediastinum. So this is another case of trauma where you can find this is classical continuous diaphragm sign. So there is air below the mediastinum, below the heart, okay, which is communicating between these two diaphragm. In CT scan you can see better, this is air column. Okay, so this is useful sign to differentiate between pneumothorax and pneumomediastinum. This is classical sign for pneumomediastinum. This is continuous diaphragm sign. This is very important sign which is used to be asked in NEET-PG and your MD examination. Another sign in trauma is Necklerio V sign. When air is collected between mediastinum and medial border of diaphragm. So it looks like a V, victory. This is mediastinum and this is diaphragm. This is Necklerio V sign. Again, case 4. So he is 35-year-old male and he was diagnosed as left lower mass and confirmed as a adenocarcinoma 15 days ago. And the staging was is a stage 1 or 2A. Stage 1, T2. Okay. So can you comment on this X-ray? So in this X-ray, if we doesn't know history, we will think of left side hydropneumothorax. Since we know history, so we can diagnose as this patient as left side pneumonectomy. So because of lung mass, it is curative surgery for lung mass. So whole lung mass taken out. So no lung is here. Okay, and you can see very well suture line. Can you see this stapler? So this is left side pneumonectomy. Now you will ask question why this fluid is there. So whenever there is acute surgery of like a pneumonectomy, so there once they have removed lungs, so there is potential space, and one potential space is there in immediate post-operative period. There is reactionary fluid inside the thoracic cavity. So this is reactionary fluid, especially in the beginning of post-operative period. Okay, so this is left side pneumonectomy acute condition. So similar patient after few months when there is fluid absorption. So here you can see there is no fluid. So this is again left side pneumonectomy, but it is chronic, and you can see there is broken rib also because while surgery they have cut the rib and removed the lungs. So this is left side pneumonectomy chronic one. Now case number 5. She is 30-year-old female, typical history of tuberculosis like low grade fever, loss of weight, loss of appetite, cough. And if you see X-ray, in X-ray you can find there is right CP angle blunting. although there is segmental consolidation, but we are focusing on this part, right side pleural effusion. But the sad part is when we examined her in ultrasound, we couldn't find any fluid. Why? Because mostly we are doing ultrasound in posterior part and axillary part, especially in female. Okay, but in this patient, if we do lateral x-ray, we can see there is no fluid in CP angle, posterior CP angle. Okay, so this is posterior part, you can find vertebrae, and this is anterior part. So posterior part, which is the most common site for pleural effusion, there is no fluid, CP angle clear, posterior side. But if you see anterior side, there is fluid, CP angle blunting at anterior side. So take home message for all of you, if you find effusion in chest x-ray, examine anterior also. Doesn't bother about male or female, you have to examine anterior part, like this case. So this is pleural effusion anterior side. This is another interesting case, case number 6. She is 60-year-old female. She was having acute seizure. For that, she brought to emergency. Resident put endotracheal tube. But after putting endotracheal tube, when X-ray was done, she was having low oxygen saturation. Okay, so what is the probable diagnosis? So if you see this X-ray clearly, in this X-ray you can find there is opacity of whole left hemithorax. Mediastinal shift is not there to opposite side. And if you see carefully, you can see this is endotracheal tube coming centrally, coming and going towards right side. So this is left lung collapse due to right bronchus intubation. Resident push endotracheal tube inside. So the tip of endotracheal tube gone in right side and there is no air in the left side. That's why left lung become collapse. So what is the treatment? Nothing. Just you pulled out endotracheal tube 2 or 3 centimeter. Okay. So once we pulled out the endotracheal tube little proximal, air got inside the left lung and left collapse gone. So this is take home message for you. Once you are intubating the patient, you have to listen by step clearly and you have to rule out lung collapse. Now this is our last case, case number 7. 50-year-old male, he is chronic smoker, cough, hemoptysis, but he was having no fever, dull aching chest pain left side, but there loss of weight and appetite, and tuberculosis was negative, gene export was negative. So he went to a private practitioner. He thought cough is there, hemoptysis is there. When he saw this X-ray, so in this X-ray, if we see this X-ray, this is chest X-ray PA view. Right CP angle is clear. There is no problem of right parenchyma. But if you see carefully left side of lung, you can see there is CP angle blunt on left side. And if you see carefully, there is opacity left pericardiac region. This is consolidation. Okay. So based on this X-ray and based on this clinical history, private practice started empirical ATT. And this X-ray was taken in July. And after giving ATT, there is no symptomatic relief. Okay. Now he came to us in November after 4 months and 3.5 months. When we did X-ray, there is chest X-ray PA view. We can see there is left side pleural effusion and this opacity which was there pericardiac become more large. This is large consolidation or opacity. So if you see carefully, you can see left heart border. It means this opacity is not silhouetting left heart border. But if you see carefully, there is silhouetting of left hemidiaphragm. Okay, so as I told you in previous classes, if any opacity which is silhouetting heart border, it means it is there in lower lobe. If any opacity which is silhouetting cardiac border, it is there in their anterior lobe. I mean upper lobe. So this is opacity in posterior lobe of left lung. So if you do CT scan, we found that there is opacity which is smooth rounded opacity in left lower lobe. So this is left lung collapse and this is pleural effusion. Okay. So when we did bronchoscopy, we found that there is complete obstruction of left lower lobe. So what is our diagnosis? Our diagnosis is left lower lobe collapse due to left intrabronchial mass in left lower lobe. When we did histopathology, it came out as a squamous cell carcinoma. So can you imagine a patient of squamous cell carcinoma? He was being wrongly treated by anti-tuberculosis drug for last 4 months. So we should not miss any finding in chest X-ray. If we see clearly this X-ray, we can have suspicion then this patient is having something in left side. So this is left lower lobe collapse due to malignancy. So with this, thank you very much. So if you like this video, please like, share with your friends and write me in comments. So I have lot of videos, chest X-ray and other pulmonary topics. So if you want to see all, you can subscribe my channel and watch my videos. So with this, thank you very much.